that's a great question. I want to make it very clear. So HIPEC by itself offers some treatment for some patients. We sometimes do just the HIPEC without any surgery, and I'll expand that more in a moment. But traditionally, HIPEC is part of this comprehensive multidisciplinary treatment that involves cytoreductive surgery to remove all the tumor that is visible. And the ideal target of the heated chemotherapy is to target small microscopic residual disease. So that means cells that are floating throughout the abdomen and pelvis, they need to attach to develop a tumor nodule and then develop a blood supply. And HIPEC is very good at preventing that. How does it work? Well, it's a combination of heat. Heat by itself at these temperatures of 42 degrees has the capability of killing cancer cells. Radiation is a perfect example. It's just concentrated heat at a very high degree. Then the second part of HIPEC is the chemotherapy itself, which also kills cancer cells, and it's supersized, if you will, or potentiated by warming it up. So not all the chemotherapeutic agents are made to be used during HIPEC because they don't have any synergy with the heat. And the third component of the heated part of the treatment is that any of those tumor nodules will be softened up by the heat and will increase the depth of penetration of the heated chemotherapy. So if you think of a tumor nodule, when you give HIPEC, there is the outer portion of the tumor nodule being bathed on chemotherapy. And then there is a second component, which is that chemotherapy gets absorbed and through the blood vessels attacks the inner core of that particular tumor nodule. So that's briefly how HIPEC works.
Question coming in, Dr. Esquivel. How many times can a person receive HIPEC?
So there is no limit. HIPEC is well tolerated. We use nowadays anti-adhesion cellulose layers, so to prevent scar from the operations. Many years ago, literally 3 decades ago, I think it was in 1991, I published a paper with Dr. Sugarbaker on repeat HIPECs, and we did it up to 5 times. In other words, I think that the limiting factor is going to be the amount of adhesions or the non-response to the therapy. It's not that there's something in particular, like intravenous chemotherapy, that the toxicity gets too high. In this case, the limiting factor is the biology of the tumor, number one, and number two, the distribution in the abdomen and pelvis because of adhesions.